The point about PTSD is very interesting, and I completely agree that if you are going to come with someone who's got PTSD, they've likely also got the importance of looking at pregnenolone and DHEA. You know, people shouldn't be taking this. It's like, you can do whatever you want. I mean, it's just an opinion, and it's a perspective. If you had a probability of developing side effects and permanent side effects, the argument that most people agree on is that dutasteride will have a lower risk than finasteride if an appropriate dose is used.
I guess maybe we should talk about the brain, because there's actually really similar changes in the prefrontal cortex of people's brains. And you don't want to upregulate that type 3 5-alpha reductase. That's one of the theories why you can develop more manic symptoms. You think about, someone in the special forces comes home, they have a little PTSD, they have muscle wasting, they've worked hard and, served their overlords for better or for worse. And then they come back, and instead of doing, maybe some ketamine therapy or whatever, counseling, they take a whole bunch of anabolic steroids, and then that kickstarts a manic episode, which is probably related to that same process, just in the prefrontal cortex, which is the decision-making part of the brain.
I'll just elaborate more on a couple of points that Kyle made there. And so firstly, when he was talking about the reduction in low-grade prostate cancer and the increase in severe prostate cancer, there's two trials, one on finasteride and one on dutasteride, which are like these big long-term. So if people want to look it up, the finasteride one's called the prostate cancer prevention trial, and then the dutasteride one's called the reduce trial. Similar kind of outcomes in both. The thing that I think is interesting when people are talking about data is that what these studies found was about I think it's about a 30%, give or take off the top of my head, reduction in prostate cancer from finasteride. But what I think people also need to look at is that that's a difference between 10% and 15% when you're comparing placebo to intervention. So the first one sounds like way more significant, whereas the second one's like, well, that's not actually that big of a change. So data can be misconstrued when it's looked at in a certain way. But what they found in the reduce trial was that there was about so it's 24.8, so we'll call it 25%. Reduction in the incidence of prostate cancer with the 5-alpha reductase inhibitor, but then there was a 25% increase in high-grade Gleason cell tumors. So it was kind of like being like, well, there's less chance of getting it, but then if you get it, it's going to be more severe. And then the other thing that's been interesting to look at is how it impacted mortality long-term. And there's some different data suggesting that it didn't make a difference, and then there's some other studies suggesting that there's reduced mortality when it comes to lower androgen levels and so forth. So that's that point. The point about PTSD is very interesting, and I completely agree that if you are going to come with someone who's got PTSD, they've likely also got, and Dr. Mark Gordon talks about this fantastically, the importance of looking at pregnenolone and DHEA and these other neurosteroids in veteran-induced PTSD when there's trauma to the head. If you come in and then upregulate androgen production massively, especially if you use these non-bioidentical anabolic steroids, you create this basically environment, exactly what Kyle said, that's going to induce mania because you're massively upregulating excitatory neurotransmission. And this is a huge detriment to these guys because, particularly if someone has got PTSD and their mental health's not good, they're more likely to take, how do I put this without getting banned? Long-term solutions for short-term problems, we'll say. So all of that stuff is completely correct. And the thing that I think that's interesting that Kyle's brought up, which, like we both mentioned before, that we hadn't heard of, is this idea of if something is going to be used, this pulsatile approach is important. And when we look at these studies that's showing the detriments, particularly when we look at in rats in finasteride, they're injecting them with the equivalent of taking like a whole packet at once and then injecting that. The doses they're using are just insane. And I would argue that if you injected paracetamol at that dose, you'd probably cause any kind of issue as well. I mean, there's very few things you could inject that much of and not cause a problem. So a lot of the research when it comes to these things is not using the kind of dosing that Kyle is talking about. And I think this is why these discussions are so important, is for the sake of nuance. I guess the question I'd like to ask Kyle, because I know that this is going to be the thing that a lot of people are going to be asking about, and this is the bit that Stephen will probably clip. If a gentleman comes to you, like let's say hypothetically, on TRT or aren't on TRT, if there's a difference with those, please elaborate. who's started to progress with hair loss, let's say mid-20s, and they're wanting to take some form of 5-alpha reductase inhibitor or a combination with something like topical minoxidil or whatever. What are your, what's your perspective, approach, recommendations on that in terms of if they did do that, what kind of protocol would that look like? Because I'm assuming for hair loss, does that pulsatile approach, is that still efficacious?
Yeah, that's a good question. So the first question is the same question I'd ask if they came in and asked and said, hey, doc, how about some TRT? I would say, what benefits are you looking to get from this? And then what have you been experiencing, or how has your life changed or may potentially change that you can look out of it? And depending on the age of the patient, let's say they're a 20-year-old, I'm probably just going to tell them right off the start that it's pretty much almost no matter what, the benefit is not going to outweigh the risk in a 20-year-old. So they can look at other options. And I know we mentioned, DHT inhibitors or androgen receptor blockers. There are lots of promising candidates that we've gone into that for the purpose of this discussion, we don't have to. Maybe they look at a topical version of one of those that is not systemically absorbed. Topical finasteride is systemically absorbed significantly, and topical dutasteride is minimally systemically absorbed. It's very lipophilic, although it has kind of a borderline particle size, but it can certainly be systemically absorbed quite a bit. So you have to be really careful with the 1% formulations, because if you apply 1% every single day, it will be absorbed, which if you're not against some systemic absorption, that's okay. But then are you really going to pulse your topical? It's getting pretty complicated. But you can use topical dutasteride because of something called a dose-dependent half-life. Same thing as Tylenol, same thing as aspirin, where you have a different order pharmacokinetics. So basically how the body breaks down each drug, whether it's regardless of what molecule it is, your body's going to break it down in one or multiple ways. And after it reaches a saturation point, it's going to break it down very slowly. Example of this, if you take 2.5 milligram capsules of dutasteride every day, its half-life is going to be at least 12 weeks. If you take one 40 milligram dose, which is the highest dose I've seen it studied in humans, then its half-life is going to be even longer than 12 weeks. But if you take a very minimal amount, and again, talk to your doctor about the concentration, but in general, 0.25% or less. I do like to prescribe the 1%, but then you dilute it with other things and then apply, let's say, half of a milliliter just in the areas that most need it. A tiny bit, but a clinically insignificant amount is systemically absorbed. And before it's circulated, it has already been broken down, because it's broken down very quickly in very low doses. So it is difficult, and most, if you're just getting topical dutasteride or finasteride, then it's probably been prescribed too high, and you almost might as well be on the orals. But I do like topical dutasteride regimens for some individuals. But to be safe, for cases, for example, let's say you're desiring fertility, then I also recommend not even taking topical dutasteride during that case. And then if you're on oral dutasteride, again, kind of similar to TRT, if the aesthetic benefit is a bonus, then great, we'll kind of add that to that side of the scale. But there should really be other benefits that you're looking for, which are far more rare if you're not on a TRT protocol.
Mm-hmm. And what would those other benefits be?
Of taking a 5-alpha reductase inhibitor, it would be if your androgen pool is high in basically any other organ system in the body, your prefrontal cortex, your liver, cardiac tissue. Skin is mostly an aesthetic benefit, but there is some benefit to it. And prostate tissue, you could probably find a few other examples. But in general, it would be decreasing the androgenicity of your either extremely naturally high testosterone. Some people do have it. It's relatively rare. There's actually a pretty big YouTuber that is currently being worked up publicly. But he's not a patient of mine, otherwise I obviously couldn't talk about it. But he's publicly being worked up for extremely high natural testosterone levels. I want to say 2,500 total, over 2,000. So they're concerned for a tumor that was producing it. His YouTube channel starts with an S, and he's a pyromaniac, which kind of makes sense. But anyway, it is rare, but it does happen.
If you've just started TRT, it is completely normal to feel overwhelmed and confused. There's a lot of new territory to cover, and there is a lot of conflicting information. I wrote TRT 101 so that you can have everything that you need to know in an instruction manual in one place that you can refer back to, that you can have all the questions answered before they even come up. TRT 101 is my best practice approach for TRT from start to finish, and it contains everything that you need to avoid all the challenges and pitfalls that I've seen come up in my clients over the last 5 years. You can check it out via the link below.
It reminds me of that movie. I can't remember what it's called, but it's when the guy climbs the El Capitan mountain, and he's free climbing it, and then they looked at his brain and he didn't have any receptors for cortisol in his brain. I was like, well, that makes sense. Interesting. Of course, he's a pyromaniac. So I want to give a bit more context for people watching, and then I want to ask you a follow-up question because I think this is fascinating. So for those who aren't familiar, there was a lawsuit against the manufacturers of finasteride, which is Merck, and this was in 2016. If people want to read about it, I don't know if I'm pronouncing this right, Reuters. I'm going to call it Reuters. That's probably wrong. I don't care. But the title is Court Let Merck Hide Secrets About a Popular Drugs Risk, if people want to Google it. And you can actually read this section of the transcript. And what the prosecutor says is, quote, "So you knew internally that these sexual adverse effects were prolonged or lengthened or never went away, and that is something that would impact sales in a negative way, right?" And the answer was yes. Of course, the defendant's lawyer objected to the question, but it was sustained. So this was basically a class action against finasteride for this post-finasteride syndrome, which the company lost and had to pay out. It was 4.3 million. And since then, they've had to alter the package insert to say that side effects will resolve to side effects may resolve, which is, we'll leave that for another day in terms of how the pharmaceutical business works. So I guess my follow-up question to that, which I find this fascinating. So is the proposition that because dutasteride is significantly less systemically absorbed topically than finasteride, a little bit still goes in, but significantly less because of the structure of the molecule. And what you're also suggesting, because I don't work with it whatsoever, but it wouldn't surprise me that the doses being used on average would be far too high because of the amount of nuance in this. I guess what I'm questioning is, and I don't want to make this like a black and white question, but this is kind of the questions that I think people are going to have, so I'd like to ask it. Would the idea be that obviously using topical dutasteride versus topical finasteride, let's say if you had a probability of developing side effects and permanent side effects, is the argument that, I guess the argument that most people agree on is that dutasteride will have a lower risk than finasteride if an appropriate dose is used. And then I guess the question that I'm saying is, if someone is using this like absolute minimal effective dose of dutasteride in the kind of dosing regimen that you're talking about and the form that you're talking about, I'm sure that you couldn't say that, and obviously you can't say we could guarantee that you could never get post-finasteride syndrome from that. But I guess the question is, would the odds be so significantly reduced that it becomes a virtually non-risk factor, or such a low risk factor that it's not worth worrying about, or significantly less to worry about, would be my question.
Yeah, it's a good question. Of the relatively large number of patients I've had on oral and topical dutasteride, including patients with post-finasteride syndrome, and because it can be used to treat post-finasteride syndrome, because it's essentially, I mean, it's not exactly the opposite of finasteride, but it is about 50 times stronger on enzyme type 3, and it's about 11 times stronger on enzyme type 1. And finasteride is at least 4 times stronger on enzyme type 2. So let's say you decrease the dose by 10x of the dutasteride, which is kind of what we did. It's about the same on type 1. And I can also send you a chart where you can put up where the enzymes are concentrated. To make it more complicated, it's not like the prostate is pure type 3 and hair is pure, and the hair follicle is pure type 2, and pubic skin is pure type 2, and non-pubic skin is pure type 1. But we can send that just for reference, but it's a bit esoteric. I guess to answer the question more directly is side effects still do happen. If let's say someone's on a pretty high dose of topical dutasteride or a moderate dose of oral dutasteride, then often they get side effects like low libido. I haven't seen OCD or a lot of the mental side effects other than libido and drive, where I have seen those with finasteride. It's not necessarily inducing a true OCD disorder, but moving someone further to the spectrum. Maybe it's technically more OCPD would be the classification, and then that can resolve. So don't really see that with dutasteride, but side effects certainly do occur. But the incidence of side effects, as you mentioned, is low enough to where treatment is reasonable in a lot of individuals, especially individuals on TRT. And especially females too. I know we're concentrated on TRT in males, but that's kind of a whole nother discussion, which maybe we do have at some point. That would be fun.
Yeah, this is fascinating because I think one thing that I guess haven't articulated well in my critical stance of finasteride is that, and I like to relate this to I'm going to use the vegan argument as an example, and I don't endorse a plant-based diet, but I think there's a big difference between someone sitting here who's a vegan saying, this is why you shouldn't eat meat, versus coming up to them in a restaurant and taking the meat off the plate. It's two very different things. So I think when I'm saying, people shouldn't be taking this, it's like, you can do whatever you want. I mean, it's just an opinion and it's a perspective. But I think the most important thing is that for guys who are going to go, hey, I recognize that there's risks here, because I think with all medical interventions, there are risks, especially things like surgeries and TRT as well. None of these are perfect solutions. They're all imperfect solutions. And I'm sure that they'll get better as time goes on. I'm sure hopefully one day we'll find a way to do TRT without shutting down natural production. And I think the most important thing for guys who are going to be like, hey, I'm going to do this anyway. Like I had a client the other day he's like, I'm a model. I'm a career model. Like I can't lose my hair. And I'm like there are instances where it's like, okay, we have situations where something has to be done. I think it's so important that rather than being like, never do anything ever, being like, if you are going to do something, then this is what you should do due to XYZ reasons, and reducing increasing the reward and reducing the risk in terms of the ratio between the two, as long as there's that understanding that there is still a risk and so forth.
The tricky thing with testosterone that we have to look at is that testosterone is good for you up to the point that it's not. A lot of the anecdotal outcomes as well really conflates bioidentical testosterone with anabolic steroids. Finding something productive and stressful that's got that nice balance that if you got out the other side of it, you'd be like, that would be meaningful. When I was going through my rehabilitation for my brain injury, if it wasn't for the testosterone, I wouldn't have gotten through it, because that was just this insurmountable period of what I would call living hell.